I'd like to welcome our next speaker, Dr. Abdul Hamid Hassan, who is one of the first members of SHMS and the main gynecologist for the guidelines over the years. He has been fighting with all the members to get the guidelines at the stand we have it today. Thank him very much for this. He was a consultant family physician at the International Medical Center in Jeddah. Thank you very much.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman. I will go to present the guidelines from SHMS. But before that, I would like to remind you about two boiling topics. I said this 3 years ago. The first is sprint. Sprint in 2015 is still boiling till now. Last few weeks, we received Sprint Mind, telling that intensive blood pressure control is much better to delay cognitive impairment. The second boiling topic is the American guidelines for hypertension last year, talking about the magic number. Diagnosis of hypertension is 130/80. To start drug treatment is 130/80. To target blood pressure is 130/80. So there is nothing called 140 now. All is talking about 130/80. This is our guidelines. It is update of the 2011 guidelines. The group who developed the guidelines includes physicians, pharmacists, dietitians, guideline development experts, and methodologists. They are coming from different sectors from the whole kingdom. In general, the evidence analyses we depend on are published guidelines and research from the 2010 to 27. But also we asked the editors to look for more recent trials or the evidence to add it in the guidelines. Each section passed through 4 steps for the development of the guidelines. At first, it was the steering committee to look for the fulfillment of the authorship criteria, including the scope of the manuscript, its size, references, and the clarity. Further, it was reviewed for content validity by 1 or 2 co-authors, followed by a subgroup editorial board, and finalized by the steering committee. The editorial subgroup developed the Feynman consensus statement that considered the clinical evidence, applicability, cost effectiveness, and the cultural values. The guidelines includes chapters related to hypertension management common with other major authorities' guidelines, including the comorbidities and other target patients like elderly and women. We have the chapter for hypertension during Hajj and Ramadan since we started to develop our guidelines more than 12 years ago. And this is unique for our guidelines. Another chapter that it deserves mention is hypertension among children. Again, we started to include children since the beginning of the development of Saudi guidelines. Each edition includes a chapter about Saudi guidelines. I would like to remind you the Canadian didn't include children except for the previous last 2 editions of their guidelines only. But we included children for more than 12 years among the patients treated in our guidelines. The second point, the author of this chapter included Saudi data. The nomogram for the children is based on Saudi children, not exported from North America or Europe. No, it is Saudi data that we used in this chapter. Now I will go through some of the chapters of the guidelines, not all of it. The first area to discuss is which machine. We said that wrist machine are not accurate 100%, And we recommend the upper arm machines because any change in the position will change the readings. While Hypertension Canada in 2018, for the first time, they said you use electronic upper arm is preferred, but wrist devices could be used. If the arm circumference is too large and the cuff is very small, you can use the wrist machine. This is new recommendation from the Canadian guidelines. The Canadian also stated that in the clinic, you should use the automated, unattended machine. What does it mean? It means that you attach the machine to the patient, you press a button, you leave the room. The machine will not work. After 5 minutes of rest, the machine will start to work, measure 3 times, 1 minute apart, then calculate the average. This is the preferred method of blood pressure measurement in the clinic, and it is called automated, unattended machine. Where to confirm the diagnosis? If the blood pressure in the clinic is more than 180, 110, it is hypertension and you start the treatment at once. If it is below that, you should confirm the diagnosis. SHMS, we said you can confirm the diagnosis by ambulatory blood pressure measurement or by home blood pressure measurements, or if not available, you may use the clinic to diagnose hypertension. And at that time, you need 5 visits to confirm the diagnosis of hypertension. NICE, they don't consider the clinic as a place to diagnose hypertension. They said only ambulatory or home, ambulatory or home, ambulatory or home. No diagnosis of hypertension in the clinic according to NICE guidelines. This is copy and paste from Canadian guidelines this year. They put it hypertension 2020. I don't know why they put it 2020, although it is, we are still in 2018. But they put it like this. And they said the diagnosis should be out of the office, at home or ambulatory. And if it is to be diagnosed in the clinic, you should use the automated unattended machine. Classification of blood pressure. In SHMS, we said hypertension is 140/80, 140/90. But the American College of Cardiology, American Heart Association said the diagnosis is 130/80. The Canadian said if you would using automated office blood pressure, 135/85 is hypertension. If you use ambulatory blood pressure and the mean awakening blood pressure level, it is 135/85. If you use home blood pressure measurement to diagnose, it is 135/85. But if you use non-automated, the one that you attend the measurement in the clinic, it is 140/90. And if you use 24 hours ambulatory blood pressure measurement, it is 130/80. The European guidelines last August, they said hypertension is 140/90. But they said high normal 130. Keep in mind this high normal is 130 according to the European. The threshold to start drug treatment. The Americans said above 130/80 you should start a drug treatment. Except if the patient is at low cardiovascular risk, you need to start a drug treatment only if it is 140/90. And also for secondary prevention of stroke. But all other patients, you should start a drug treatment by 130/80. As you can see, if there is high-risk cardiovascular, grade 1, 130/80, you should start a drug treatment. But if it is low risk, no drug treatment for 130/80. If it is 140, it is stage 2, you should start the drug treatment and even with 2 medications if you like. This is the European. They said high normal, 130, not hypertension according to the European. But they said if it is high risk patient, you can start a drug treatment for them. So they started also treatment from 130, not from 140, at high normal patients. And if it is 140, if there is high risk, immediate drug treatment. If low risk, lifestyle modification for 3 to 6 months only. If not to target, you should start drug treatment at once. This is high normal drug treatment if a patient is at high risk. For elderly, up to 80. If the blood pressure is 140, you should start drug treatment. 140, grade 1, you should start drug treatment. So this is my table to show you that the European and the American are talking the same. No change at all, no difference. 130 to 139, low risk, no drug for the American and the Canadian. High risk, there is drug treatment for stage 1 in the American and high normal in the European. If it is 140, low risk drug treatment after 3 months according to the European, but immediately according to the American, and high risk immediate drug treatment for them. So you can see that there is no discrepancy between the American and the European guidelines. The Canadian are totally different. They didn't start the drug treatment except if it is 160 over 100, if the patient is at low risk. If the patient is at high risk, it is 140/90 to start the drug treatment. Target blood pressure. In SHMS, we recommend 140/90 for most of the patients. For diabetes, we said 140/90, but you may go to 130/80. For the elderly, we said 150/90. But all other patients is 140/90. For chronic kidney disease, 130, you need to target your blood pressure. The American didn't say that. The American said all patients should be below 130/80. But look at the American, the same guidelines. Look at the top upper left corner. Normal blood pressure, less than 120. So it is 119, 117, 115. What they said, promote optimal lifestyle modification. Optimal lifestyle modification. 6 interventions. And in their guidelines, they said optimal lifestyle modifications among normotensive patients will reduce the blood pressure by 14 to 18 millimeter mercury. We started by 120 or less, and we reduce the blood pressure by 15 millimeter mercury. So they are aiming at 105 or 110. How it comes, I don't know. This is very low level. But how it comes to order optimal lifestyle for that level? This is the European Cardiovascular Prevention 2016. What they said, less than 120 is the target for high-risk patients. This is the Canadian this year. What they said, less than 120 for high-risk patient. Not 150, not 140, not 130, not 120, less than 120. Who are high-risk patients? These are high-risk patients. And you can see it is all, not and. So any criterion is considered high-risk patient, and you should target, including very elderly. 75 years, you should target blood pressure less than 120, very low target. But this is the guidelines, cut and paste from the Canadian guidelines. This is the European, last August. No 140/90 anymore, except chronic kidney disease. But nothing called 140/90 anymore, even for the European. If you can see, not below 120. So 120 is good, 121 is good, 122 is good, but not 119. For the diastolic, not 80, 79 or below, but not below 70. This is the European this year. First line drugs. I am talking about without compelling indications, without comorbidities, only hypertension. In SHMS, we put 4 classes at first line: diuretics, ACE inhibitors, ARBs, and calcium channel blockers. But we said there is a place for beta blockers for patients younger than 60 years of old. And we said also patients who are well treated on beta blocker, keep them, don't change their treatment if they are stable and well controlled in beta blockers. But the first lines is the 4 classes we mentioned. The NICE guidelines since 2011, they said RAS blocker, calcium channel blockers, thiazide diuretics, another diuretic, alpha blocker, then beta blocker. They put beta blocker number 7 for first line, non-compelling indication. This is the American guidelines, 4 classes only. They don't consider beta blockers as first line for non-compelling indications. The Canadian initial treatment, 5 classes including beta blocker, but only for younger than 60 years of age. For isolated systolic hypertension, the Canadian said the first line are only 3 classes: thiazide diuretics, ARBs, or calcium channel blockers. The European said the same, like the NICE guidelines, like the British. First, RAS blocker, calcium channel blockers, diuretics, then the same 4 classes, then you can add spironolactone, alpha blocker, or beta blocker. Again, they don't recommend the beta blocker as first-line drug for non-compelling indications. They said beta blockers only for heart failure, angina, MI, atrial fibrillation, or young women. This only beta blocker as first-line medications. And when they talked about beta blocker, they said it should be cardioselective vasodilating beta blocker, not in any beta blocker. And they mention in name nebivolol, not any beta blocker, not any vasodilating beta blocker, not any cardioselective beta blocker. Nebivolol in name. And they put 5 reasons why they said nebivolol: for central blood pressure, for aortic stiffness, for endothelial dysfunction, for new onset diabetes, and sexual dysfunction. So if you would like to use a beta blocker, use nebivolol, not other vasodilating cardioselective beta blockers. This is from the American guidelines, cut and paste. Nebivolol dose from 5 to 40 milligram once daily. Very high dose. Even the drug company representative doesn't know that this dose could be used. But the American said you can use nebivolol up to 40 milligram once daily to show you how safe is this drug and well tolerated. Hypertension among patients with diabetes. In SHMS, we said it is 140/90, but it is better to go to 130/80. Canadian said it is 130/80, the target for patients with diabetes. European, they said 130 systolic, but you may go to 120, 121, 122. For diastolic less than 80, you can go to 70, 71, 72, not below 120, 70. The American Diabetes Association, in the chapter of hypertension, what they said. The first recommendation, 140/90. The second recommendation, 130/80 for high-risk patients. This is very strange because all patients with hypertension are at high risk with diabetes, because diabetes is a cardiovascular disease equivalent. So all patients should be 130/80. Why they put 140/90? They don't have the courage to remove accord from their mindset. No more accord anymore. The target should be 130/80 or even lower, as I will show you from their guidelines. The third recommendation in the guidelines, lifestyle modifications. If the blood pressure is more than 120, so if the patient with diabetes and his blood pressure is 121, lifestyle should be, not maybe, should be initiated. Again, lifestyle among a patient with normal blood pressure will reduce the blood pressure by 14 to 18 millimeter mercury, so it will reduce it to very low, 105, 110, very low level. The last point, antiplatelet. In SHMS, we recommend low-dose aspirin for hypertensive patients if they are well controlled and at low risk of gastrointestinal bleeding. The European didn't recommend the aspirin for primary prevention among patients with hypertension. The Canadian recommend the low-dose aspirin for patients above the age of 50 with hypertension. Thank you.